Hello?
Hello, sir.
ஆஸ்கி இருக்குல்லைங்க டாக்டர் ஸ்ரீதேவி ஆஸ்கி இருக்குங்களா?
இவங்க மேடம் பண்றாங்களா சார்?
ஓகே. மேகலை மேடம். ஓகே.
பண்றாங்களா?
ஓகே. டாக்டர் ஸ்ரீதேவி என்ன கேஸ் பரவாயில்லைங்களா? சென்னையில கண்ட்ரோலா, அண்டர் கண்ட்ரோலா?
ஆமா சார், இப்போதைக்கு அட்மிஷன்ஸ் குறைஞ்சிருக்கு சார்.
குறைஞ்சிருக்கு. ஓகே.
நடுவுல எல்லாம் பெட் இல்லாம, வேக்கன்ட் பெட் இல்லாம வர பேஷண்ட்லாம் திருப்பி அனுப்பிட்டோம். அந்த சிச்சுவேஷன் மாறி இருக்கு. இப்ப வர பேஷண்ட் எல்லாரையும் அட்மிட் பண்ண முடியுது.
மேடம் மேகலை மேடம் ஐசிஹெச் பரவாயில்லைங்களா?
So we are actually planning to close them, but 1 or 2 are coming. We can't just close down also. கொஞ்ச நாளைக்கு we have to keep it வேற வழி இல்ல.
I think post தீபாவளி ஏதோ ஒரு சர்ஜ் இருக்குன்னு சொல்றாங்க. I think
சொல்றாங்க சார், ஆனா ஒண்ணும் வந்த மாதிரி தெரியல. டிஹெச்ல ஒண்ணும் சொல்லல, தெரியலங்க சார். பார்க்கணும்.
அங்க கோயம்புத்தூர்ல சார்?
கோயம்புத்தூர் is better madam, better. But past ஒரு few days கொஞ்சம் cases increasing now.
பாண்டிச்சேரியில கேஸ் கம் டவுன் வெரி லோ லெவல் சார்.
பரவாயில்ல. பட்
அதனால வந்து இப்போ வந்து ஹோம் குவாரண்டைனே நிறுத்திட்டாங்க பாண்டிச்சேரியில. இன்னையில இருந்து அட்வைஸ் வந்து இஸ் டு ஸ்டாப் ஹோம் குவாரண்டைன். எல்லாமே இன்ஸ்டிடியூஷனலைஸ்ட் கேர் தான்.
இல்ல பெட்டர் டெஃபினட்டா கோயம்புத்தூர்ல. பட் இது கொஞ்சம் ஒரு 1 வீக் ஒரு பர்சன்டேஜ் ஒரு 5% இன்க்ரீஸ் ஆன மாதிரி தெரியுது. பாட்டாய்க்கு
சார் ஸ்டார்ட் பண்ணிக்கலாம் சார். 2 o'clock ஆகுது.
Good afternoon to everybody. On behalf of IAPTNSC, I welcome Dr. Nagalai Suresh Kumar. She is Professor of Pediatrics, Institute of Child Health, Chennai. Welcome, madam. I welcome Dr. Sridevi A. Narayanan. She is Associate Professor of Pediatrics, Kilpack Medical College, Chennai. I welcome Dr. Sridevi.
Thank you.
The third program you are doing, and I really appreciate your encouragement. I welcome Dr. Sridevi, and I welcome Dr. Student Dedupati, Nandini, and Aram. Welcome all the students. This is the 11th case presentation from our medical colleges. Doing very well. Welcome all the students who participate in the program. I welcome one and all for this event. And again, on behalf of IAPTNSC, I welcome one and all for this wonderful event. And I over to Dr. Magalai Madam and Dr. Sridevi.
Welcome students for this class. I think the presenter can start presenting the case.
Okay, ma'am. Good afternoon, ma'am. Good afternoon, sir. Today is a case presentation of pneumonia.
So you've given us the diagnosis at the outset, huh? Okay.
Ma'am. Okay. Shall I start, ma'am?
Yes.
Patient details: name Master Dhanush, age 3 years 1 month, sex male, address Porosevakam, informant mother, reliability is good. Chief complaints: cough for 5 days, fever for 5 days, breathlessness for 4 days. The child was apparently normal 5 days back, after which he developed wet cough, which was insidious in onset, progressive in nature, not associated with expectoration, no diurnal or postural variation, no aggravating factors, relieved by medication, not associated with post-UC vomiting. Fever was there for past 5 days. It was high-grade fever, intermittent in nature, associated with rigors, no aggravating factors. It was relieved by medication. Child was normal during the interfebrile period. Fast breathing for past 4 days, which was acute in onset. No aggravating or relieving factors. History of chest retractions present. History of running nose for past 4 days with watery discharge present. No history of coughing up of blood. No history of wheeze. No history of bluish discoloration of lips or extremities. No history of orthopnea on PND. No history of ear pain, ear discharge. No history of mouth breathing, snoring, and voice change. No history suggestive of aspiration of food or foreign body aspiration. No history of diarrhea. No history of any rashes. No history of convulsions and vomiting. No history of feeding difficulties, headache, malaise, and lethargy. And there was no history of loss of weight or loss of appetite and bad child rearing practices. Ma'am, shall I continue, ma'am?
This is a 5-year-old child, right?
No, ma'am. 3 years, 3-year-old child, ma'am.
Chief complaints of cough, fever, and difficulty in breathing. Right? So
Yes,
you
ma'am.
told
Yes,
there are
ma'am.
no diurnal variations. So
Yes, ma'am.
what do you want to say? So cough, which is more prominent in the night, nocturnal cough. Tell me a few causes
Yes,
where
ma'am.
you can get a nocturnal cough. Diurnal
Ma'am, ma'am, bronchial asthma, ma'am.
yeah, bronchial
Hello.
asthma, yes. Any other condition where the cough is more predominant on early morning cough, suppose in the mornings?
Ma'am.
So usually in bronchiectasis, they say the cough is more in the mornings and you get copious amount of sputum in the mornings, right? Okay.
Okay, ma'am.
In a child with sinusitis or a child with a G reflex, the cough is
Okay,
more
ma'am.
on assuming that when they lie down, right? So usually a
Okay, yes,
nocturnal
ma'am.
cough. The bed, they usually get a cough. So we think of
Okay,
those
ma'am.
conditions. Okay. Okay. You gave us an elaborate history, right? And you told
Yes,
us the
ma'am.
child has no precipitating factor for the breathlessness. What do you mean by that, doctor? Go back to your no aggravating or relieving factors.
Yes, ma'am.
What is that?
Ma'am, for aggravating factor in case of asthma, it could be seasonal, ma'am. On exposure, when the child exposure to any dust or pollen grains, or when the season is summer, the fast breathing gets aggravated.
Induced asthma, cold induced asthma. Yes, with asthma, yes, maybe
Yes, ma'am.
have some aggravating
Yes.
factors. Okay.
Yes, ma'am.
Okay. You also told us there is no history of any bluish discoloration and all this.
Yes,
So
ma'am.
let's start
Yes,
history
ma'am.
and you want to talk about bluish discoloration. What is that?
Ma'am, cyanosis, ma'am.
Sinus. What kind of case is this? You said it's a case of pneumonia. So why should
Yes,
the
ma'am.
child develop cyanosis?
Ma'am, because of breathlessness,
Yes. This
ma'am, the
can go on
saturation
for,
may drop, ma'am.
child can go on for respiratory failure, can develop
Yes,
cyanosis.
ma'am.
Yes, good.
Okay,
So we
ma'am.
wanted to also find out how is the progression of the breathlessness. Yes, cyanosis.
Yes, ma'am.
Okay. Okay. So this is a child with cough, fever, and breathlessness. So I think it
Yes,
is a
ma'am.
respiratory system that is involved mainly. Okay.
Yes, ma'am.
Okay. Okay. So any
Okay, ma'am.
past history?
Yes, ma'am. There was a past history of similar illness 1 year back for which a child was admitted untreated with IV antibiotics. No history of recurrent respiratory tract infections. No history of exanthematous fever. Not a known case of bronchial asthma or allergy. No history of any surgery and no history of any blood transfusion.
Yeah, what exanthematous fever you'll be interested in? This is a 3-year-old child
Yes, ma'am.
which can precipitate a respiratory problem.
Ma'am, sorry, ma'am. I can't hear, ma'am. Sorry.
This is, you said no history of exanthematous fever. So what
Yes, ma'am.
exanthematous
Measles, ma'am. Measles, ma'am.
measles? Okay.
Yes, ma'am.
So is there no history of any surgeries, no history of blood transfusions? How are they related to a respiratory problem?
Ma'am, routinely we used to mention past
Yes.
history, ma'am. That's why.
We are asking about surgery and blood transfusions. Okay. So
Okay,
in a
ma'am.
child with a respiratory illness, I think you need not ask all these questions. Suppose
Okay,
it's
ma'am.
a child with fever and epidemiology, maybe you can ask about blood transfusion. So, like the small children know,
Yes,
they
ma'am.
can ask relevant history, right? Okay.
Okay, ma'am. Okay, ma'am. Okay.
Sridevi, anything else, ma?
No, ma'am.
ಡಾಕ್ಟರ್ ಯಾರು
Yes, ma'am.
ಕೋ ಸ್ಟೂಡೆಂಟ್ ಯಾರು ನಿತ್ಯವಾ ನಿತ್ಯ
Nitya, Nandini, ma'am.
ಯಾ ನಿತ್ಯ ನಂದಿನಿ ಒನ್ ಆಫ್ ಯು nocturnal cough la when do you get cough in sinusitis, when do you get cough in asthma, what is the timing of cough?
Ma'am, sinusitis is as soon as they lie down, the
Very good.
this thing will drain into the throat, cause irritation and cause cough, ma'am.
Very good.
Asthma is more towards the morning, ma'am. 2 to
Very
3
good.
a.m. that time, ma'am.
Okay, so the child will wake up with cough and asthma, whereas immediately on lying down, if the child has cough, you should think in terms of postnasal drip, that is sinusitis, or as madam said, GERD, any gastroesophageal reflux. These are the two things which will cause cough immediately on lying down, rather than your asthma. Okay, and breathlessness, you said it is acute in onset or it is insidious in this child?
Ma'am, insidious only, ma'am.
Yeah, I remember you mentioning acute.
Yes, ma'am. Sorry, ma'am.
What should you think of, doctor? Suppose there's a sudden onset of breathlessness, what should you think of?
Foreign body aspiration, ma'am.
Usually a foreign body, right? Foreign body you have to think of. Okay.
Okay.
Okay. If the child had presented without respiratory, without fever, just with cough and respiratory distress, what will be the first thing you will think of?
Foreign body, ma'am. Foreign body aspiration.
Okay.
Anything else,
Ma'am.
Cough, breathlessness. We were talking about that. It can be an asthma, right? It can be a visa, get a cough and then get respiratory distress. Yes. Think of a wheezing also. Okay. Continue.
Shall I continue, ma'am?
Continue.
Okay. Antenatal history, birth order 2, child was born out of non-consanguineous marriage, registered and immunized, iron and folic acid tablets were taken, no history of any fever with rash, dating scan, anomaly scan, growth scan were done and found to be normal, all trimesters were uneven full, natal history, term delivery, normal vaginal delivery at hospital, birth weight 2.9 kg, cried immediately after birth, breastfeeding was started within 30 minutes of delivery. Neonatal history, meconium was passed at 5 hours, no history of NICU admission, no history of prelacteal feeds, no history of neonatal jaundice and asphyxia. Child was exclusively breastfed for 6 months and breastfed continued up to 2.5 years. Ma'am, shall I proceed, ma'am?
Continue.
Okay, ma'am. Immunization history, child was immunized up to date, yearly influenza and pneumonia vaccine were not taken. Developmental history, gross motor, right tricycle, alternate feet going upstairs, fine movement, fine motor, tower of 9 blocks, copy circle, social and adaptive, shares toys, language, ask questions, knows full name and gender. For the present age of 3 years, 1 month, the latest developmental milestones have been achieved in all 4 domains. Therefore, the child is appropriate for the age. Development is appropriate for the age. Okay, ma'am. Shall I continue, ma'am?
Continue.
Okay, ma'am. Diet history, the child consumed mixed diet history obtained by 24 hours recall method, and required calories is 1200 kilocalories, ma'am. The consumed calorie is 1065 kilocalories, and the protein is 20 gram is required. Consumed is 18 gram. Deficit, calorie deficit is 135 kilocalories and protein deficit is 2 gram. Okay, ma'am. For family history, no history of similar illness in the family, no history of bronchial asthma in the family, no history of passive smoking, no history of allergy in the family. Socioeconomic history, lives in semi-paka house which is well ventilated, overcrowding present, no separate kitchen, separate toilet and bathroom, fuel LPG, water is obtained from municipality, stored in overhead tanks and boiled before drinking. Class 4, upper lower according to modified Kuppuswamy scale. Waste disposed in street bins. History of mosquitoes breeding in nearby area. There's history of rodents present and no history of livestock near the house. Contact history, no history of contact with tuberculosis or COVID-19 patients. Summary: a 3-year-old male child who came with chief complaints of cough and high fever for 5 days and fast breathing for 4 days, associated with chest retraction and running nose for 4 days. The child belongs to an upper lower class family upper lower class family according to modified Kuppuswamy scale. He was born out of non-consanguineous marriage. His immunization history is up to date according to national immunization schedule. He consumes a diet with calorie deficit of 135 kilocalories and protein deficit of 2 gram. So probably a case of lower respiratory tract infection. So I would like to examine the respiratory system.
In the past history, you said the child had a similar episode illness and got admitted 1 year back.
Yes, ma'am.
Now also he has a respiratory infection, right?
Yes,
so,
ma'am.
Tell me some causes for recurrent pneumonias. You said you're going to present a case of pneumonia. So
Yes,
somebody
ma'am.
has recurrent respiratory infections or recurrent pneumonia. What will be?
Okay, ma'am. When the child presents with GRD, cleft palate, and the child has cystic fibrosis, the child is immunodeficient, this recurrent pneumonia can occur, ma'am.
Okay. And few other conditions. Suppose child has got an anatomical problem in the respiratory system. Suppose a child has got a lobar emphysema or a cystadenamatoid transformation as a sequestrated lung. So it's got a sequestrum or a cyst in the lung. That also will cause recurrent respiratory infection. So you must think of anatomic causes.
Okay.
Of immunological problems, or it can be an aspiration, GRD.
Yes, ma'am.
So all these things also you have to keep in mind.
Okay, ma'am.
Sorry for the disruption. Sethupathi, I think show your face, video, and Nandini and Nitya.
Sure,
on your video.
Sure,
okay,
please.
I think you are present or you have to show your face also.
Sir,
Sethupathi also, please. Right.
Sir, since I'm sharing the PPT, I can't switch on the video, sir.
Okay, possible. Okay, no issues. At least we have seen you, right? Okay.
Yes, ma'am.
We also talked about his immunization status, right? As per his national immunization schedule is up to date, right? For his thing.
Yes, ma'am.
But what are the vaccines you think could have been given? It would have helped them. These are 2 infections now, right?
Yes, ma'am.
What vaccine he got, it would have been much better for him.
Pneumococcal vaccine could have been given, ma'am.
Pneumococcal vaccine, okay. But what else?
Ma'am, influenza vaccine, ma'am.
Influenza vaccine also. Influenza vaccine, pneumococcal vaccine. So they also help with reducing the incidence of respiratory infections, right? Okay.
Okay, ma'am.
Okay. So continue.
Okay.
1 minute. Among the vaccine the child has received, which are the vaccines you think are protective against pneumonia?
Ma'am, BCG, ma'am. H influenza B. And then measles.
Yes.
1 second, ma'am.
Yeah, mainly hip and measles.
Pertussis, ma'am. Yes, ma'am.
Mainly hip and measles. You should mention these both.
Okay, ma'am. Shall I continue, ma'am?
Continue.
Yeah.
Okay, ma'am. General examination. After getting consent from the mother, the child was examined in sitting position. The child was alert. Hydration was fair. Tachypneic, subcostal, and intercostal retractions are present. No pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy, and no pedal edema. Vitals, pulse rate, it was 100 per minute, regular in rhythm and character, normal in volume, measured in radial artery. Respiratory rate, 55 per minute, mostly abdominothoracic, intercostal and subcostal retractions were seen. Blood pressure, 100/70 millimeter mercury in supine position in right arm. Temperature, 100 Fahrenheit, measured in axillary region. Head to toe examination, head normal, fontanelles were closed. Face, no dysmorphic faces. Eyes, no redness, no conjunctivitis. Ears, no discharge, no pain. Nose, flaring of ala nasi present. Oral cavity, no dental caries, no halitosis, no thrush. Good oral hygiene, no high-arched palate or cleft palate. Neck normal, tongue no cyanosis, chest retraction present and fast breathing was present. Limbs normal, skin no redness and no rashes. Hair black, no color change, luster normal. Spine and cranium normal. Anthropometry, Ma'am, anthropometry weight observed value is 14 kilogram, ma'am. It was according to WHO chart, it was between 50 to 50th percentile. Height 93 centimeters, and it was between 15 to 50th percentile. Weight for height, it was 50th to 85th percentile. Head circumference, it was 48.3 centimeter, between 15th to 50th percentile. Middle upper arm circumference 16 centimeter. It was above 50 percentile. Ma'am, shall I continue, ma'am?
No, continue.
Okay, ma'am. Respiratory tract infection, examination. Upper respiratory tract, nose, watery discharge present, flaring of Allan is seen, nasal septum normal, no deviations, sinus, no tenderness present, pharynx, no tonsillitis, no sign of pharyngitis, and no cleft palate. Inspection, lower respiratory tract inspection, shape of chest elliptical, spine normal, trachea appears to be in midline, apex beat not seen, chest moves symmetrically on both sides, subcostal and intercostal retractions are seen. There is use of accessory muscles of respiration, both nipples are at same level, no sinus, cars, visible pulsation or chest wall deformities. Palpation, inspectory findings were confirmed on palpation, no tenderness, chest moves equally on both sides, no local rise in temperature, position of trachea appears to be in midline. Apical impulse felt in the left fifth intercostal space, medial to the mid clavicular line. Vocal fermenters increased on both sides. Percussion, uh, ma'am. While percussion, the note was impaired on two regions, ma'am. It was left side inframammary and right side infraaxillary. Sorry, three regions, ma'am. Left side inframammary, right side infraaxillary, and left side infrascapular, and rest of the areas were resonant. Auscultation, ma'am. We heard diffuse crepitations, ma'am, and we could appreciate V's on a few areas, ma'am, such as on right side it was supraclavicular uh, and infrascapular, on left side on axillary area, and the fine crackles are heard on inframammary, left side inframammary, and left side infrascapular, and right side infraaxillary, ma'am. Bilateral air entry diminished.
Okay.
Ma'am? Yes, ma'am. Vocal resonance increased on both sides.
Okay. Hereditary
Okay,
diminution.
ma'am. Vocal resonance increased on both sides. Yes, ma'am.
Okay.
Hello, ma'am.
Vocal resonance increase on both sides all over, entire chest?
No, ma'am. It was diffusely increased, ma'am. The child was, it was a bit uncooperative, ma'am. So we couldn't elicit on all areas, ma'am.
Okay.
Vocal fremiters and resonance we found to it's found to be increased diffusely, ma'am. So
Okay. Okay.
okay, ma'am. Systemic examination, cardiovascular examination, S1, S2 heart, no murmurs. Abdominal examination, no mass per abdomen, no organomegaly. CNS examination, no focal neurological deficit present. Here is an 3-year-old, he is a 3 years 1 month old child, male child, who came to the hospital after mother noticed cough and high grade fever for 5 days, fast breathing for 4 days, with running nose for 4 days. Examination revealed intercostal and subcostal retractions and use of accessory muscles of respiration. On percussion, impaired resonance is seen. Vocal fremiters and resonance appeared is found to be increased. Auscultation revealed diffuse crepitations on both sides. Provisional diagnosis, it's a case of acute lower respiratory tract infection, probably pneumonia. Investigation, CBC, X-ray chest.
1 minute. So,
Yes, ma'am.
so what is the pneumonia actually?
Ma'am, it's an infection of lung parenchyma, ma'am.
Okay, so infection of lung parenchyma, is it called pneumonia?
Yes, ma'am.
When you have bilateral findings, then what will be your diagnosis? Usually don't call it as a pneumonia, no? What do you call it? Generally, we call it as bronchopneumonia rather than a pneumonia. Usually, a pneumonia, this usually involves a lobe or a segment, and you get the localized findings. No, or you say pneumonia, both lower lobes, pneumonitis, like that, right? Okay.
Yes, ma'am. Yes, ma'am.
Okay. So this child. So what are the findings? Clinical findings which tell you this is a pneumonia.
Ma'am, the child is found to have fever, ma'am. Fever for 5 days and cough for 5 days.
Examination wise,
And,
not history wise. Examination wise.
ma'am, examination wise, ma'am, I could found the vocal fremiters increased, ma'am. So vocal fremiters is increased in case of consolidation. So consolidation occurs in pneumonia, ma'am, and along with that, vocal resonance is also increased. And I could hear wheeze and diffuse.
As we localized one area, you can call it as a thing. So you won't get this finding in different parts of the chest. That is usually not the way a pneumonia will present, right? Okay.
Okay. Okay, ma'am.
So the child also has crackles and wheeze, you said. How will you explain that?
Ma'am, wheeze is a musical sound that's heard when air passes through then partially obstructed smaller airways like bronchioles or alveoli, ma'am. Uh, crackles is heard when air passes through some fluid secretions, ma'am. Like in early stages of pneumonia, there will be accumulation of exudates in the alveoli, ma'am. When air passes through that fluid, then we can hear some crackle-like sound.
Okay. Okay. So can you hear crackles and wheeze in a child with pneumonia?
Yes, ma'am.
Yeah, you can hear both crackles
Okay,
as well as wheeze also you can hear in a child with pneumonia. But in this child, instead of saying pneumonia, you can call it as a bronchopneumonia because there is involvement of both the sides of the lung. So it's more a diffuse disease rather than a localized disease. Okay.
Okay, ma'am.
Okay. So what investigations you want to do for this child?
Ma'am, I would like to do CBC, ma'am. In CBC,
Madam,
ma'am.
Madam would say something about your clinical examination findings.
Okay, ma'am. Okay, ma'am.
The vocal resonance and vocal tremendous you said, like, it is more of a comparative finding. There is no absolute thing. Like when you talk about air entry, you say air entry is bilaterally diminished, all that you say. But vocal resonance or vocal tremendous, it is a comparative finding. Compared to other areas, how is one area? So you cannot say diffusely it is increased because you don't know what is normal. How can you say it is diffusely increased? It's very difficult to make out whether it is normal or increased in all places. Only if there is a localized finding, you can say compared to other areas, this area it is increased. But otherwise, you can't say that generalized everywhere it is increased in rather. It's a difficult finding to elicit. So generally, you don't commit like that. You don't say that everywhere the vocal tremendous is increased or vocal resonance is increased. Only if there is a localization of a finding, you say in that particular place alone it is increased. Whereas scattered creps, scattered wheeze, it is accepted. You can have scattered in one area, in a bilateral you can have in different areas, like one place in infrascapular, one place infraaxillary, one place inframammary, like that you can have scattered. But scattered, it is very difficult to make out your vocal resonance, that too in the 3-year-old child. So don't commit so strongly that it is increased in all areas. Okay, it is not a wise thing to commit like that.
That's all. Just leave it to because you have a localized finding, localized thing like diminished air entry there, and then you have vocal resonance. Yes, you can think of a pneumonia, a consolidation, but not when you have diffuse findings. You don't commit like that. Okay.
Yeah, only when you have a particular region you commit. Otherwise, you don't commit. Okay, that is regarding this. Then your percussion note, what did you say?
Ma'am, percussion note, in few areas it's found to be impaired, ma'am.
Impaired.
Yes, ma'am. Okay, ma'am.
So the same area where you're hearing crackles and wheeze.
Yes, ma'am.
Okay, so the findings are there. So wherever we have findings, we have a diminished thing also, percussion note also. Is it like that?
Respiratory movements, did you measure?
Ma'am, yes, ma'am. I measured by placing my hand. No, ma'am. Respiratory movements. Yes, ma'am. I measured. It was around 55, ma'am, per minute. Respiratory cycles.
Illappa, I'm asking about respiratory movement in the chest. Was there any focal abnormality in any particular place, or was it?
No, ma'am. It was equal on both sides, ma'am.
Okay, bilaterally it was okay, symmetrical.
Yes,
The chest movements were symmetrical bilaterally.
Yes,
but I think you didn't mention, no?
Ma'am, no, I mentioned.
You mentioned about
inspection.
Okay, inspection you mentioned. Okay, even in palpation you should say.
Chest moves equally on both sides.
Oh, you mentioned. Okay, very good.
Yes, ma'am.
Okay, sorry, I just missed it.
Okay, ma'am.
Okay, ma'am. If there is going to be a tenderness in chest in the case of pneumonia, what should you think of?
Ma'am, Empyema,
Okay, very good. You should think of
pneumothorax.
empyema. Okay, okay. Very
Okay,
good.
okay, ma'am. Shall I proceed, ma'am?
Yes, ma'am.
Investigations. I would like to do CBC, X-ray chest, blood culture and sensitivity.
Okay.
Ma'am, then treatment.
Explained in the
Ma'am.
CBC, but how is the CBC
Ma'am.
in making a diagnosis of pneumonia?
Ma'am, we can differentiate whether the etiology is bacterial or viral, ma'am, with the CBC. In case of bacterial, there will be leukocytosis. Predominantly, neutrophil count will be increased, whereas if it's viral etiology, lymphocyte count will be increased, ma'am.
Okay, so the CBC may be normal, or if it is elevated, it is mostly lymphocytes which are involved. Okay. What about the X-ray chest?
Ma'am, with X-ray chest, we can see the areas of infiltration, ma'am.
Okay. So what will be the finding in pneumococcal pneumonia? Suppose we have a consolidation because of streptococcal pneumonia. What will be the X-ray?
Ma'am, streptococcal pneumonia, it causes typical pneumonia, ma'am. Typical means it's lobar. It involves one lobe, ma'am. So there will be a consolidation in infiltration involving one whole lobe.
Okay, okay. Suppose it's a viral pneumonia. What will be the X-ray?
Infiltration will be diffuse, ma'am. It will be seen on both sides of lung.
Actually, interstitial infiltrates will be seen with peribronchial cuffing. So it is more of the interstitial that is involved in a viral pneumonia. Right. Okay.
Okay, ma'am.
Okay. What else will you see in X-ray chest? Anything else can you see in X-ray chest in a child with pneumonia?
Ma'am.
Others can pitch in. Nandini, Nitya, you can
Ma'am, in
contribute.
case of staphylococcal, you can see nematoceles also.
So you can see nematoceles and then
Micro abscesses will be seen, ma'am.
okay, so the complications. So in an X-ray chest, most of them you also have to look for complications. So there can be a nematocele, or the child can develop a pneumothorax, a pneumothorax, or the child can develop pleural effusion. So what do you call a pleural effusion associated with pneumonia? What do you call that pleural effusion?
Mnemonic
Effusion. Okay, mnemonic effusion. Okay, okay. So X-ray chest will tell you all those things. Okay, what is the use of a blood culture?
Ma'am, blood culture. With blood culture, we can detect the organism which is causing this pneumonia, ma'am, so that we can choose appropriate antibody like that.
So in how many cases
antibiotic like that.
you get the blood culture positivity?
Only 10 to 15%.
Yeah, only 10 to 15%. So you need not do it in all cases, right? Huh?
Okay, ma'am.
Yeah, when a child is admitted or you have a small child is not responding to treatment, yes, you can do a blood culture. But it's a sick child, septic child, you need to do the blood culture. Okay. Any other investigation for a child with pneumonia?
Ma'am.
Suppose it's a viral pneumonia, what should you do? Do you have some tests?
COVID, ma'am. Sorry. COVID.
So we have a corona. So what test are we doing?
Yes, ma'am. Swab, COVID, ma'am, RT-PCR. You have to do COVID by taking swab.
Only of the viruses, you have RT-PCR. Okay. So now, Nandini, can you tell me what are the viruses which can cause pneumonia? We are talking about viruses, test for viruses.
Ma'am, adenovirus, ma'am, influenza virus, para-influenza virus, respiratory syncytial virus, ma'am, then rhinovirus, ma'am.
Okay, okay. So RT-PCR is available for many of these viruses. You can do. But nowadays we are doing only for corona. So we assume all viral infections. No, we don't have tests for all these. For any bacteria, are we doing RT-PCR?
Yes, ma'am. Mycoplasma, we can do PCR, ma'am.
Okay.
For Legionella.
Even for pertussis, nowadays it is available. Government of India is doing for pertussis also. So RT-PCR is available. You can do. Okay. Okay.
Okay, ma'am.
Okay. Any other investigation? Suppose child is not improving. So you're treating the child, but child is not improving. So what investigation you would like to do? The child is not improving. Any investigation you would like to do?
You can test for tuberculosis, ma'am.
Pardon?
we can
tuberculosis.
test.
Yes, you have to rule out tuberculosis in this child. Yes, you will have to do a manto test, and you have to do a put examination or a resting gastric juice for tuberculosis, CB-NAT, and all those things. So, child is not improving in our country. We have to think of tuberculosis and rule out tuberculosis. Anything else?
It rule out HIV.
HIV, yes, HIV, yes.
Any other immunodeficiency?
Yeah, immunodeficiencies. So to think of conditions which
Bronchiectasis.
persistent pneumonia or a recurrent pneumonia, and try to rule out all those conditions. Will a CT scan just be helpful in a child, managing a child with pneumonia?
Okay.
Will it be helpful? CT scan?
Yes, ma'am.
Yes, ma'am.
Yes, child is not improving, and you want to know about the anatomical involvement and all that, a CT scan test would be helpful for the child. Right? Near the bedside test available, still not possible in many places.
Want to test?
Bedside. You can also use an ultrasound. Ultrasound to make out consolidation, pleural effusions. But why it is not being utilized is because it depends on the person who's doing. Observer bias is there. So that's why many of them are not trained to do it. Many of us are not trained. So that is the problem, right? So if you get the bedside thing, it will be very much useful, right? Okay.
Okay. Okay.
Nandini, what is air bronchogram?
Ma'am, the air line will be seen in the chest X-ray, ma'am, in the consolidation, ma'am.
Okay, it is seen in consolidation, where the airway will be delineated as black lines in the white patch of consolidation. So that is air bronchogram. Okay. So Nitya, you tell me one investigation which is mandatory to diagnose pneumonia as per WHO.
X-rays, ma'am.
No, ma. Question and the catch the question. There is no investigation which is mandatory to diagnose pneumonia. As per WHO, the diagnosis of pneumonia is purely clinical. So, based on which clinical sign do you diagnose pneumonia as per WHO?
Fast breathing and chest retraction, ma'am.
Very good. Not chest retraction. Fast breathing is the sign. So, tachypnea or fast breathing is the sign to diagnose pneumonia as per WHO. So, tell me what are all the age appropriate rates and which is what the definition of tachypnea.
Ma'am, for less than 2 months old, greater than 60 breaths per minute will be considered as tachypnea. For 2 months to 1 year old, greater than 50 breaths per minute will be considered for pneumonia. And for more than 1 year old, 1 to 5 years old, greater than 40 breaths per minute will be considered as pneumonia, ma'am.
Considered as tachypnea. Okay, that is the age appropriate rate cutoff. What is the significance of chest retraction?
Ma'am, it indicates the presence of respiratory distress, ma'am. Respiratory effort is increased in the baby.
Okay. So,
severe pneumonia. In other words, it is a severe pneumonia. Mostly needs an inpatient treatment. You need to admit the child and treat the child if the child has got a chest retraction. More severe pneumonia.
What retraction do you specifically want to look for? Adults, you talk about intercostal, subcostal, everything you talk about. In pediatrics, what retraction do you look for?
Subcostal, intercostal, and suprasternal interactions.
Intercostal child intercostal it is mainly the subcostal retraction as per the IMNCA. So how do you describe the subcostal retraction?
Ma'am, it's indrawing of the chest below the rib cage, ma'am.
Okay, so during inspiration or during expiration? The chest will move in during what
inspiration,
phase? You should know to describe. You should say that the chest will move in when the child is having in the phase of inspiration. Normally during inspiration, it should balloon out. Whereas if there is retraction, the subcostal region will get retracted. It will move in when the child is breathing in. So that is very specific of this thing of subcostal retraction. What is the what is the posture the child should be seated, a 3-year-old, for you to examine the respiratory system?
I'm sitting position, ma'am.
Very good. Sitting in mother's lap. Okay, you should say sitting position. Ideally, sitting in mother's lap. All examination should be done in a non-threatening way. Okay, the child should not start crying. If the child starts crying, automatically there will be retraction, there will be tachypnea. You will not be able to find out the rate and retractions. So the child should be quiet and the child should be seated in the mother's lap. That is ideal posture for examining the child. So how do you check the respiratory rate? Ideally by inspection or by palpation? Nandini.
By inspection, ma'am, we have to see the pulse and look for the respiratory rate, ma'am.
Ideally, it is by palpation, not inspection, because you may miss few breaths. So ideally, you should put your hand on the abdomen of the child and you should count. Count for how long?
1 minute, ma'am.
Count
Complete
for,
1 minute, ma'am.
yeah, completely for 1 full minute. Then only you should say whether it is tachypnea or not. Okay. Madam, ninge kelunga.
So now you know how to do the counting for the breaths. Okay, so it's always palpation. You keep your hand over the abdomen and count for 1 full minute. Why should you count for 1 full minute, ma?
Child's breathing is erratic, ma'am. So we can miss some breaths in the inspection, ma'am.
Periodic breathing. Small children, they have periodic breathing. So you need to count for 1 full minute. Otherwise, you will either under count or over count. Okay. Yes. Okay.
Okay, ma'am.
So what is the management for this child? So what are the indications for admitting a child with a respiratory infection or a pneumonia in the hospital? This is home management for this child.
Yes, ma'am.
So what do you do home
Hello, ma'am.
management?
Ma'am, because according to IMNCA criteria, this falls to category of pneumonia, ma'am, because the child has fever, cough, and
This child has tachypnea as well as
tachypnea, fast breathing, chest retraction, ma'am.
Then
There's no need.
management. So when you have chest retractions or indrawing, it becomes a severe pneumonia, right? Then the child needs to be referred to a facility. Am I right?
Yes, ma'am. Okay.
The child has only tachypnea, then it is only pneumonia. Then you can do home management. But if the child has chest indrawing, it becomes a severe pneumonia. Then this child needs to be referred. Okay. So let us assume this child is not having chest retraction. Child has only tachypnea, fever, okay, and cough.
Yes, ma'am.
So you do home management. So what is the home management you will advise?
Ma'am, home management, we have to give antibiotics, ma'am. Oral amoxicillin, 40 milligram per kg per day, and we have to give medications to soothe the throat. And
sufficient. What is the
2 times a day, ma'am?
Is 40 milligrams enough, or you need to give an higher dose?
Enough, ma'am.
This is according to what, per 40 milligram per kg per day?
Ma'am, IMNCA guidelines, ma'am.
40 milligram per kilogram per dose and given in 2 doses.
2 divided doses. When go up to 90 milligram per kg, right? When you're giving an oral amoxicillin, you can go up to 90 milligram per kg per day in 2 divided doses. Yes, you can give. What else do you do?
Ma'am, we have to give medications to relieve the cough, ma'am. Ma'am, if there is fever, we can give hello, ma'am.
You give paracetamol to relieve fever.
Yes,
what else? You said
fever.
To relieve something. What is that?
Cough.
Cough. So what medication you will give to relieve cough? As per IMNCA, is any cough syrup advised?
No, ma'am. In children, cough syrup is mostly avoided, ma'am. It can cause depression of the central nervous system.
So what they're supposed to do? What you can do? What is advised as per IMNCA? Anything they mention?
Any home remedy?
Home remedies you can try, no?
What is the home remedies which are advised for cough?
Don't know, ma'am.
Okay, you commonly advise warm water, honey, and tulsi water. These are the home remedies advised. Honey, warm water, tulsi water. Okay.
Okay, ma'am. Okay, ma'am.
So yeah, you also said monitor the food and fluid intake and reassess the child. Okay. So when will you reassess the child and what are the danger signs you'll tell the mother because you're going to do home management,
Yes,
right?
ma'am.
Okay.
Yes, ma'am. Ma'am,
The danger
we have to
signs
some danger signs are refusal to feed, lethargy, conversions.
okay.
Inability to feed, ma'am.
Strider in calm.
Inability to drink.
Inability to drink. Strider in calm.
So the respiratory distress increases. You say now, academia only you'll keep the child at home. But if the respiratory distress increases, child develops retractions, then she has to bring the child immediately. Or the child is not able to take feeds, becomes lethargic, then also she has to bring the child back. Okay, okay. Okay. Suppose this child has retractions and you have admitted the child, then what will be your management? So you are working in the hospital, you're going to become an house surgeon within few months, then you will be managing the child in the hospital, right? You have admitted the child, and what will you do?
Ma'am, if the child is so severe to get admitted, we can, for severe pneumonia, we can give IV ampicillin, ma'am. IV ampicillin and gentamicin.
So what is the organism? What are the common bacteria which can cause pneumonia in a 3-year-old child?
Ma'am, streptococcal pneumonia.
Streptococcal pneumonia, yes.
Hemophilus influenza, ma'am.
Hemophilus influenza.
Okay. Now are we getting hemophilus influenza nowadays?
No, ma'am.
Why are we not getting hemophilus influenza?
It's being vaccinated, ma'am.
Vaccination.
So the antibiotic, what we are going to give is a presumptive antibiotic. Presumptive antibiotic therapy depends on the age of the child, the common organism in the community. In your community, you will have an organism, or maybe in your hospital, commonly you will be getting microorganisms. So that and the clinical presentation, whether the child is present, very toxic child with complications, then you have to go for an higher antibiotic. So the preventive treatment also depends on all this, the age of the child, community, and then the presentation of the child and also the immunization status of the child. If the child has got a pneumococcal vaccine and the influenza, then you can give ampicillin. Suppose the child has not received these vaccines, then the drug of choice would be cefotaxime or ceftriaxone. Okay. So it depends on the condition of the child and also the immunization status of the child. So you start IV antibiotics. Okay. And what are other supportive treatment you should give for a child who is admitted?
Ma'am, if the saturation is low, ma'am, if it's below 92, we can give nasal oxygen, ma'am.
The child needs support, oxygen support in the form of nasal oxygen. When all can you give nasal oxygen?
Ma'am,
Mask or hood, ma'am.
high flow nasal oxygen.
Pardon?
High flow nasal O2.
Yeah, HFNC, yes.
CPAP.
Nasal
Yes,
cannula, yes. Then
continuous CPAP, ma'am.
CPAP, yes. CPAP,
BiPAP.
yes. And if the child is in respiratory failure, may have to intubate and ventilate the child also. So respiratory support is important. Then what else?
Ma'am, to maintain hydration, IV fluids are given, ma'am.
Yes, yes. And then nutrition, right? So initially the child is very thin, you will give only IV fluids and later on maybe NG2 feeds and then oral feeds. Gradually as the child improves, you go for oral feeds. You must take care of the hydration, nutrition, the respiratory support, antipyretics. All this is important, right? So you have a definitive treatment and a supportive treatment you need to give. Yes. So what are the complications you will watch for? Nandini and who's other Nitya? What are the complications you will expect or you watch out for?
Ma'am, the respiratory distress can worsen, or the child can develop lethargy, refusal to take feeds. There can be excessive sleepiness, or the other complication, pleural effusion and all can develop. So we have to look for that also.
Examining the child is very, very important. Watch for increasing respiratory rate. Air entry you must check. Yes, then.
Convulsions, ma'am.
Okay. So complications, you tell me complications related to the respiratory system and other complications. To the respiratory system, it can be a pleural effusion. Then
Empyema, ma'am.
empyema.
Lung abscess, ma'am.
Septicemia, lung abscess, pleural effusion.
Yes, bronchopleural fistula.
Pneumothorax, ma'am.
Bronchopleural fistula.
Yeah.
Pneumothorax.
Pneumothorax, pneumothorax, yes. Then systemic complications.
Sepsis, ma'am.
Sepsis, septic shock, yes.
Pericarditis, myocarditis,
Myocarditis, yes.
meningitis.
Meningitis, septic arthritis.
Yes, ma'am.
Osteomyelitis, all that can happen. Respiratory system, respiratory failure, right? Okay.
Yes, ma'am.
So, respiratory complications and other complications. So you always be on the watch out for respiratory problems, complications. So whenever you treat the child, you have to also keep watching out for problems. Okay. Yes. Okay.
One of you mentioned about hood as a use for delivering oxygen. Hood is used only in newborn and young infants. It cannot be used in a 3-year-old child. Okay. Hood is nothing but a head box. It is used for smaller babies, newborns and young infants, less than 2 months or 2-3 months like that. In bigger children, hood is not used. If the child is having mild distress, what will be the other oxygen delivery devices? நீங்க சொன்னதெல்லாம் ரெஸ்பிரேட்டரி ஃபெயிலியர் அந்த மாதிரி சிவியருக்கு சொன்னீங்க. மைல்டா இருக்கு லேஸ்.
Ma'am, metered dose inhaler with spacer, ma'am.
ஐயோ என்னப்பா எல்லாமே தப்பா சொல்றீங்கப்பா. இங்க ஒரு நிமிஷம் வெயிட். ஃபர்ஸ்ட் பேக் அண்ட் மாஸ்க் வென்டிலேஷன்ன்றது it is given for children who don't breathe, apneic. Okay, so if you don't have any respiratory effort on the own, then you give bag and mask ventilation. Metered dose inhaler வந்து வீசருக்கு அதுக்கு ஆஸ்மாக்கு கொடுக்கிறது. அதுல ஆக்சிஜன் கொடுக்க மாட்டாங்க, அதுல ட்ரக் கொடுப்பாங்க, சால்பெட்டமால், ஸ்டீராய்ட்லாம் கொடுப்பாங்க. இந்த ஆக்சிஜன் டெலிவரி டிவைசஸ் படிச்சுக்கணும் நீங்க எப்படிலாம் கொடுப்பாங்கன்னு. ஸோ ரொம்ப மைல்டா இருந்தா நேசல் ப்ராங்ஸ்ல கொடுப்பாங்க, இல்லைன்னா மாஸ்க்ல கொடுப்பாங்க. பிரீதிங் நான் ரீப்ரீதிங் மாஸ்க் அப்படின்னு ஒன்று இருக்கு, என்ஆர்எம். அந்த நான் ரீப்ரீதிங் மாஸ்க்ல கொடுப்பாங்க, இல்லைன்னா ஆக்சிஜன் நேசல் ப்ராங்ஸ்ல கொடுப்பாங்க. இதுதான் ஆக்சிஜன். இது வந்து மைல்டு டிஸ்ட்ரெஸ் இருந்தா. சிவியர் டிஸ்ட்ரெஸ் கிரண்ட் எல்லாம் இருந்தாதான் நீங்க சொன்ன ஹெச்எஃப்என்சி, சிபேப்லாம். ஆப்னியாலாம் போயிடுச்சுன்னா அப்புறம் பேக் அண்ட் மாஸ்க்கும் வென்டிலேட்டரும் தான். அது அடுத்த சிவியாரிட்டிக்கு. ஓகே, ஸோ மீட்டர் டோஸ் inhaler is a drug. It is a drug used for asthma. It is not an oxygen delivery device. Okay.
Oh, so a child is not improving. You are treating the child with antibiotics. Child is not improving. What now will you think?
Empyema.
Yeah, child has developed some complications. Okay, empyema. Okay, you'll.
Empyema.
What investigation will you do to confirm it is empyema?
Ultrasound test.
What? Ultrasound test. Okay. Anything else?
Test repeat. Ultrasound test. CT test.
Is it a CT test for diagnosing empyema? What will you do? What will be the finding, clinical finding, if you have empyema?
Tachycardia, toxic look.
Okay, yes, then.
யாருப்பா புதுசா யாரும் ஆன்சர் பண்றீங்க? யாருப்பா இதெல்லாம்? designated 3 பேர் இல்லாம வேற யாரும் ஆன்சர் பண்றாங்களே.
The new voices are heard, that's right. New voices.
ஆமா மேடம், சொல்லுங்கப்பா.
Okay. What is the clinical finding in a child with empyema? Still, your diagnosis, suppose the child comes very sick on day one itself, child may be having an empyema. How will you make a diagnosis clinically? What will happen to the air entry in a child with empyema? Percussion
Decrease.
note, looking,
Decrease, ma'am. Percussion note will be dull.
what dullness you call that?
Stony dull.
Stony dull, ma'am.
Stony dullness, yes, stony dullness. So the chest wall movement will be diminished.
Movement
on
will
the
be decreased.
side, yes. Air entry will be diminished. All that will be there. So you think clinically, you think it is an empyema. So what investigation immediately ask? For what will you do? You are don't even have bedside. You don't even have time to do that investigation. What will you do?
Bedside investigation, what you can do?
USG, ma'am.
USG. Okay. That is
இல்லப்பா நீங்க as a intern, as a CRRA, as a doctor, what you can do? ரேடியாலஜிஸ்ட்லாம் கூப்பிடாம நீங்க என்ன பண்ண முடியும்?
Pleural tapping, ma'am.
Yeah, do a pleural tap. Do a tap. And if you find a pus, then it is an empyema. So what will you do for an empyema? What is the treatment of an empyema? How will you treat an empyema, ma'am?
Ma'am, intercostal drainage, ma'am.
Intercostal drainage. Antibiotics you have to give, but you have to do an intercostal drainage. Okay. Underwater sleep. Okay. Yes. Any other treatment is available which will improve the outcome? Can you instill some substances into the pleural cavity? Can you do that?
To prevent recurrence, we can go for pleurodesis, ma'am.
That is last month. Who will get recurrent pneumothorax? You've asked for the
Fibrosis, ma'am.
cystic fibrosis. Children with Marfan syndrome, illness, non-less, they can get recurrent pneumothorax. Patients like that, you can try that. Okay. You can instill fibrolytic agents into the pleural cavity. That will improve the outcome, but that is also not useful. You have to do VATS. What is VATS? What of this terminology? VATS? Video assisted
thoracoscopic surgery, ma'am.
Yeah, VATS. Well, that is also not working. The lung expansion is not good. Then we have to go for decortication. Okay. So prevent all this. So use appropriate antibiotic. Watch out for the complications. Okay. Okay. So child is not improving. It can be because of complications. Any other reason child is not improving?
Any immunodeficiency status?
The organism can be different.
Yeah. So you're not. It can be different organism. It may be tuberculosis. It can be virus. It can be a fungal infection. Right. You must think of other organisms. The child is not improving. Or as you said, child may be having an underlying problem. Child may be immunodeficient. So that all that you must keep in mind. Okay. When a child is not, or maybe your drug is not appropriate or not giving it in the thing that you have to check. That is the first thing you have to check. They are giving the correct antibiotic and giving it in the correct dose. Right? Okay. Okay. So what is the duration of treatment for antibiotics? You said oral amoxicillin. How long will you give? Minimum of 5 days, you said.
5 days, ma'am. Yes, ma'am.
How many days you should give?
7 to 10 days, ma'am.
Okay, 7 to 10 days. 7 to 10 days you give. Right. Okay. Okay. Okay.
What is the commonest comorbidity present with pneumonia, which is very important? We want to rule out in any case with the which increases the mortality.
Immunodeficiency, ma'am.
Bronchiectasis கிடையாது. Immunodeficiency may be, but that is not common. It is rare. What comorbidity, if present, will make the prognosis bad?
Malnutrition.
Very good. So malnutrition is very important. Underlying malnutrition in any case of diarrhea or pneumonia, if there is underlying malnutrition, then there is a increased chance of mortality. So those children need utmost care than those with proper nutrition. Normal nutrition or malnutrition need utmost care. Okay, so this is a 3-year-old child who is presented with pneumonia. So if this child is a child of school going age, maybe 8 years, 7 years with pneumonia, what specifically, which organism you will have to rule out apart from the usual bacteria?
Ma'am, Mycoplasma pneumonia. Ma'am.
So what is the drug of choice for Mycoplasma pneumonia?
Macrolides, ma'am. Macrolides, ma'am.
Erythromycin.
Macrolides. Erythromycin or azithromycin?
Azithromycin.
Suppose this is a child with HIV. The child with HIV, what organisms are formed? So
Pneumocystis carinii, ma'am.
pneumocystis. Okay.
Tuberculosis, histoplasmosis.
Again, tuberculosis is very common. Tuberculosis, non-tuberculous mycobacteria is common. So you have to keep in mind. What
Anaerobic organisms.
cystic fibrosis?
Staphylococcus aureus, ma'am.
Pseudomonas.
Certain conditions where certain organisms you have to think of. That's what, when you decide on the antibiotic, there are so many things you have to take into account. Okay.
Okay, ma'am.
Status of the child, the age of the child, the prevailing organism in the community. Okay, if the child has got another problem. So all these things. So a physician who decides on the antibiotic has to take into account so many things, right? Okay. Okay.
According to IMNCA, initially, which was the oral antibiotic which was advised?
Cotrimoxazole, ma'am.
Yeah. So as per old IMNCA regimens, cotrimoxazole is the oral antibiotic which is advised. But now as per WHO regimen, they've changed it to amoxicillin because they found that this is more sensitive than cotrimoxazole. So, and the response rate is better with amoxicillin, so they've changed it.
So empyema, how long will you give antibiotics? Here we said 5 days, 7 to 10 days for an hospitalized child. Okay. So the child with empyema, how long should you give antibiotics?
14 days, ma'am.
14 days. Usually about 3 to 4 weeks. No? We give it for a longer period of time, right? Okay. Okay.
Okay.
How do you manage a lung abscess? That is also another complication, no? Where we get because of a pneumonia. Can lead on to a lung abscess. How do you manage a lung abscess?
With antibiotics, and if it is very severe and the abscess is large, drainage can also be done, ma'am.
Okay, what drainage you do?
Percutaneous drainage, ma'am.
Yeah, so percutaneous usually is guided by a CT. The drainage is usually advised, but the child is not improving, or child is very septic or a large abscess, then maybe we have to do a thoracotomy and drain it. Okay. So nowadays, usually minimally invasive procedures are ideal and less invasive for the child, also less of anesthetic complications. But if it's a child, very septic child, and you need to remove the entire purulent contents, then we may have to do an open thoracotomy and do the drainage. Okay. So even for an abscess, you need to give a longer duration, about 3 to 4 weeks of antibiotics, right? So another thing, remember, there are anaerobic organisms also which can be responsible sometimes. So we may have to use drugs for anaerobic organisms also, like clindamycin and all. If the child is not improving, we have to think of all those things also. Okay.
Okay.
What is the clinical sign based on which you will think in terms of staphylococcal infection?
Ma'am, in case of staphylococcal infection,
Enappa?
Child is very toxic, ma'am. Very sick appearing child.
Okay. Any specific clinical sign?
Abscess, there'll be some systemic involvement, ma'am. Pyoderma.
Very good. Pustules. Presence of pustules in the child should make you think in terms of staphylococcal. Okay. What finding in X-ray will make you think in terms of staphylococcal etiology?
Nematocele, ma'am.
Yeah. Nematoceles in X-ray should make you think in terms of staphylococcal. What are the two drugs which are used for staphylococcal coverage? Mainly. If you're thinking. Okay. Vancomycin for what staph?
MRSA, ma'am.
Methicillin resistant staph aureus. If it is methicillin sensitive?
Ampicillin.
No. Cloxacillin.
ma'am.
Okay, cloxacillin is preferred for MSSA and vancomycin for MRSA. And clindamycin is also useful for staphylococcal. The advantage of clindamycin is it is useful for staphylococcal as well as anaerobes. So in immunosuppressed, you prefer clindamycin because it will act against both.
Cover both the anaerobes as well as your
Staphylococcal coverage.
Change over to oral Clinda also. That is one advantage we have, right? You can do that.
Okay. Then.
So how will you prevent pneumonia? So what are the things? You want preventive steps.
Yes, ma'am.
Immunization, maintaining proper hygiene, avoiding overcrowding.
Yes.
Passive smoking should be avoided, ma'am, if present.
Yeah. Passive smoking. Yes.
Indoor air pollution should be controlled, ma'am.
Yes. Take care of the nutrition of the child. Even if a child is well nourished develops a pneumonia, it's usually going to be a milder one. The outcome will be better. As madam said, if it's a malnourished child, the risk of complications and mortality is much more. So you maintain good nutrition, take all the vaccines, prevent overcrowding. So all these things if you do, okay, the risk of infection and complication arising out of the infection is going to be very minimal. Okay, yes. Shall we go for the ask key questions?
Yes, ma'am.
Vidya, anything you want to say, Sridevi?
Illa ma'am, we've almost covered everything.
Covered everything. Okay. Anything else you want? Any doubts you have? So regarding the organisms. So can fungal infections, fungus cause pneumonia?
Yes,
Yes,
ma'am.
ma'am.
Immunocompromised individuals.
Okay, what are the organisms will you expect there?
Histoplasmosis.
Yes.
Aspergillosis,
Aspergillosis, mucormycosis. Okay.
blastomycosis.
Yes. Your pneumocystis, so all these immunocompromised individuals, you must think of all uncommon organisms. Yes. Okay. Yes. Okay. So asking questions, I think you have doctor. Can you?
நான் ப்ரொஜெக்ட் பண்ணவா மேடம்? இப்போ நீங்க ஸ்கிரீன் ஷேர் பண்றத ஸ்டாப் பண்ணுங்கப்பா, அப்பதான் நான் ஷேர் பண்ண முடியும்.
Okay, ma'am. Yes, ma'am. I stopped sharing, ma'am.
Yes, pa.
Okay.
Yes, madam. தெரியுதுல மேடம்?
Yeah. So this is the first case. You have a 3-year-old male child who has history of sudden onset choking, cough, and breathlessness. So there's an X-ray for you. What do you think is the cause for this problem?
Foreign body.
Foreign body.
Foreign body. Explain the X-ray finding. Foreign body which side?
Right side, ma'am, due to hyperinflation.
Where is the hyperinflation? Right side or the left side?
Left side.
Left side, ma'am, left side.
Hyperinflation. Okay. So right side, what is there in the right side?
Infiltrates, ma'am.
No, ma'am.
Foreign body is on the right side or it's on the left side? Is there a mediastinal shift?
Yes, ma'am. Right sided mediastinal shift.
So what do you call that as? You say collapse on the right side, but then compensatory emphysema on the left side. But does it look like that? Looks like an obstructive emphysema on the left side. Okay. So this is a foreign body with an obstructive emphysema on the left side. Okay. The left-sided foreign body.
Your right-sided bronchus is clearly seen. Your left-sided bronchus is not clearly seen. Okay. So there is an obstruction in the left side, which is causing obstructive emphysema.
Okay,
Next program, madam.
Next part. This is a 9-year-old child with history of fever for 5 days, cough for 3 days. The child is otherwise well. There is no breathlessness. Older child is having cough and fever, but he is happy going around. No breathlessness. Father wanted an X-ray, so we have taken the X-ray, and this is the X-ray finding.
Ma'am, since it's is in school-going children, so it could be mycoplasma, ma'am. Mycoplasma pneumonia.
So child is
Atypical.
otherwise well. So it's called a walking pneumonia.
Walking pneumonia.
Otherwise you are well, but X-ray might give you a surprise. Okay. This
Okay,
is
ma'am.
the walking pneumonia, atypical pneumonia, usually a mycoplasma. What is the common problem? Other problems children with mycoplasma can have. Of course, this child also is anemic.
Hemolytic anemia, ma'am.
There can be an hemolytic anemia due to
Cold agglutinin
cold
antibody.
agglutinin. So that also you have to keep in mind. Okay. Yes. The next.
Other features, sometimes they may present with abnormal LFTs. They may present with jaundice and abnormal LFTs also. So any child presenting with pneumonia with jaundice, you should think of atypical organism. Okay.
Okay, ma'am.
Okay, ma'am.
This is the third one. This is a child with history of fever and chills for 3 days, cough for 1 week, breathless, toxic looking, has high grade fever with increased total count and neutrophil predominance. So what is the X-ray finding?
I could see a cavity,
Staphylococcus aureus, ma'am.
Pneumatocyl.
Pneumatocyl.
இவ்வளவு பெருசா தெரியுதேப்பா.
The
okay,
big
ma'am.
thing, big neutrophils won't be so very big. Huh? So what else?
Cavity, ma'am.
Lung abscess.
Cavity, lung abscess.
Lung abscess. This is a lung abscess, right? This
Okay.
is a lung abscess, a toxic looking gel with a very high grade fever, increased neutrophils. So this is a lung abscess. Okay.
Okay.
Pneumatocyls are usually thin walled cavities. இதுல நல்ல thick wall தெரியுது பாருங்க. So இது வந்து sick childனா இது வந்து lung abscess. Non sick childனா it may be a you can think of cavity. வெறும் எக்ஸ்ரே காமிச்சு கேட்டாங்கன்னா. So sick childனா கண்டிப்பா lung abscess தான் சொல்லணும்.
Okay, ma'am.
Next போவா மேடம்.
So this is a 3-year-old male with history of upper respiratory tract infection. Child had a running nose and fever for 5 days, cough and fast breathing for 2 days. So small
Pneumonia, ma'am. Viral pneumonia.
Bronchopneumonia, ma'am. Viral pneumonia.
Viral pneumonia. So there is an upper respiratory tract infection and then going in for breathlessness and fever. So it's a viral pneumonia. So it's like bilateral interstitial involvement. So that's very common in viral diseases. Okay. What are the likely organisms? The virus?
Respiratory syncytial virus, ma'am.
Yeah, RSV,
Adenovirus.
Ma'am,
parainfluenza.
influenza, para-influenza virus, ma'am.
COVID virus.
Certain viruses you have drugs, no? So what is the drug you give for influenza?
Oseltamivir, ma'am.
Oseltamivir.
Oseltamivir. Okay. Okay. The next one, the last one. This is a nasty question. I mean, I'm sorry, this is time and day. So 1-year-old Lapta was brought to the hospital for cough for 3 days, fever for 2 days, difficulty in breathing for 1 day. There is no vomiting, no convulsions. Child is able to take breastfeeds. Febrile, tachypnic, respiratory rate of 56. The first ones, the first retractions, no stridor. So what is the IMNC classification?
Severe pneumonia.
Severe pneumonia, ma'am.
So this is severe pneumonia. So what do you do? Why do you say this is severe pneumonia?
Because
Fast.
Retractions, ma'am.
Yeah, there is fast breathing as well as chest retractions. So this is severe pneumonia. So what do you do for this child?
Admit the child and parental antibiotics are given, ma'am.
Admit the child. Suppose you're working in a peripheral institutions, or what do you do?
Ma'am, we have to refer the child to higher centers, ma'am.
Give first dose antibiotic
First
and
dose
then
of,
refer.
First dose antibiotic, give paracetamol, take care of the nutrition of the child so that the child does not become hypoglycemic, and then you transfer the child to the higher institute. Okay. Anything else you all want to know? Respiratory cases, most of the time the diagnosis of pneumonia is made clinically. We need not even do an X-ray. Even an health worker should know to make a diagnosis of pneumonia. The IMNC has helped us a lot. So it has given us guidelines how to make a diagnosis of pneumonia even in areas where you don't have an X-ray, right? Okay, and also oral drugs are available. You can treat pneumonias with oral drugs. You need not always admit them, provided the child is not immunocompromised, not malnourished, not very sick. You can do a home management for these cases. Okay. Yes.
Ma'am, on doubt, ma'am.
Yes.
Ma'am, we call it as an atypical pneumonia, right, ma'am? Or
Yes.
atypical pneumonia or bronchopneumonia or interstitial pneumonia are same, ma'am. In some books, the classification, they have given 3 classifications, ma'am. Lobar pneumonia or typical pneumonia. Atypical pneumonia, atypical pneumonia means it involves interstitium.
Atypical pneumonia, what we generally call it as atypical pneumonia is usually caused by your mycoplasma, chlamydia. They are always called as atypical pneumonia in older children. Interstitial pneumonia is often because of viruses and nothing. But what book does it say that they are all the same?
Pathological diagnosis is not given importance. நீங்க சொல்றது வந்து pathological diagnosis. So நம்ம பொறுத்த வரைக்கும் mostly when you see a child, it is the clinical diagnosis. So in clinical terms, atypical pneumonia it doesn't mean interstitial pneumonia. It means caused by atypical organism, that is mycoplasma pneumonia. Whenever we say atypical pneumonia, we mean the pneumonia caused by mycoplasma pneumonia. We don't mean the viral pneumonia. Whenever we say interstitial pneumonia or viral pneumonia, it is used interchangeably. So both are not synonymous in clinical sense. Okay. Regarding pathological sense, it may be synonymous. But when it comes to clinical case presentation and clinical discussion, it is not synonymous. Both are different entities. வேற ஏதாவது சொல்லணுமா மேடம் உங்களுக்கு?
இல்லப்பா.
ஃபர்ஸ்ட் எடுத்த உடனே காஃப் வித் எக்ஸ்பெக்டேஷன் சொன்னீங்களே டாக்டர். ஐ மீன் நோ எக்ஸ்பெக்டேஷன். எக்ஸ்பெக்டேஷன் எந்த ஏஜ்ல இருந்து வரும்?
Above 5 years, ma'am.
More than 5 to 7 years. Why?
Okay.
Ma'am, below 5 years, they tend to swallow the sputum, ma'am.
Then they don't generate sufficient pressure to expectorate. Expectorate na in chest la irundhu veliya kondu varudhu. Expectorate na the bringing out of chest. So to bring a phlegm out of chest, they have to generate sufficient pressure. So that cannot happen in a child with a small lung whose vital capacity is small. So it doesn't happen less than 5 to 7 years. Only beyond 7 years they are able to bring the phlegm out of the chest. Till then they can only swallow it. They cannot bring it out of the chest. So in any child 3-year-old, you don't expect it to be have expectoration. But you can have a, what do you call that kind of cough?
Dry cough.
No expectoration, but the mother
Wet
feels
cough,
that there is phlegm. Yeah, you should call it wet cough without wet cough or moist cough, but no expectoration. Okay.
You said post-acid vomiting. When your presentation, you told me about post-acid vomiting. So what infection is most often associated with post-acid vomiting?
Pertussis, ma'am.
Yeah, pertussis. Okay, but
what non-infective cause of post-acid vomiting?
GRD.
GRD la reflex nala cough varum. Cough nala vomiting varadu. Asthma pa. One non-infective cause which causes post-acid vomiting is asthma. Typically, they will say, "Papadam the urimi vaandi eduthuradhu." So it is very typical of asthma and pertussis. What are the pertussoid infections you know of?
Cough will resemble a pertussis cough, no, like oof, and then they go for vomiting. It's called pseudopertussis.
Chlamydia and mycoplasma.
No virus and your chlamydia, right? They can cause something similar to your pertussis. Okay. What is afebrile pneumonia? They will have cough, but they will be otherwise well, no fever also.
Viral.
Small and
Chemical pneumonitis, ma'am.
yeah, chemical pneumonitis. Any organism?
Chlamydia, ma'am. Chlamydia trachomatis.
Febrile pneumonia. Okay, yes.
Chemical pneumonitis, other than infective cause, what is the commonest cause in children? Commonest cause of chemical pneumonitis, non-infective chemical pneumonitis in children.
You only told me chemical pneumonitis. So what?
எந்த chemical cause பண்ணும்?
No, those babies getting admitted.
Kerosene.
Hydrocarbon, ma'am.
Commonest is hydrocarbons. The commonest hydrocarbon we encounter is kerosene. So kerosene poisoning, they may develop chemical pneumonitis. But another thing is chemical pneumonitis also, they may have fever. It is not necessarily without fever. So fever doesn't mean it is only infective. Any inflammation will cause fever. So in even chemical pneumonitis, because of inflammation, they may have fever. Okay. So chemical pneumonitis may present with or without fever. It is not that it should not have fever. You know, there is no thing. It can have, the child can have with or without fever. Okay.
So we said the child is not improving it with immunodeficiency or tuberculosis. Any other conditions you can think of? Child has a pneumonia like patch, but not improving with the antibiotic. You have given antifungal. Anything else?
The heart disease.
Think of eosinophilic pneumonia. Can be venous granulomatosis and other conditions which will present pneumonia but not improve with your treatment. Okay. Any worms may be associated with pneumonia.
Loeffler syndrome, ma'am. Loeffler syndrome.
Pardon?
Loeffler syndrome, ma'am.
Loeffler syndrome. Yes, Loeffler syndrome. So it can be ascariasis, bronchiolitis. So that also you have to keep in mind. Eosinophilia and the pneumonitis patch. All that you must keep in mind. Child is not responding to think of uncommon conditions causing the problem. Okay. First, you must ensure that your treatment is correct. You're given a correct antibiotic, correct dose. All that you make sure if that is not there, then you think of other uncommon reasons why child is not responding to the treatment.
Other common tropical illness which can uncommonly present with pneumonia. Just they should think of this condition also when the child with pneumonia is not improving. உங்களுக்கு தெரிஞ்ச காமன் டிராபிக்கல் இன்ஃபெக்ஷன்ஸ் எதெல்லாம்ப்பா? அதுல எதுல நிமோனியா வரலாம்?
மலேரியா.
மலேரியா கிடையாது. அப்புறம்
டெங்கு.
டெங்கு கிடையாது. அப்புறம்
லீஷ்மேனியாசிஸ்.
அதெல்லாம் கிடையாதுப்பா. காமன் டிராபிக்கல் இன்ஃபெக்ஷன்ங்கற நீங்க என்ன லீஷ்மேனியாசிஸ்லாம் சொல்லிட்டு இருக்கீங்க? என்ட்ரிக் ஃபீவர். Okay, typhoid. Sometimes typhoid may atypically present just with pneumonia, with no sign below the diaphragm. Okay, so any child with pneumonia who is not responding, you should also think in terms of typhoid. That may be a rare manifestation. இதெல்லாம் rare. எடுத்த உடனே டிஃபரன்ஷியல் டயக்னோஸ் ஆஃப் நிமோனியாக்கு டைஃபாய்டு சொல்லிடாதீங்க. இப்போ நம்ம லாஸ்டா டிஸ்கஸ் பண்றது எல்லாமே அன்காமன். இதெல்லாம் லாஸ்ட்ல வருது.
The common things are always common. So check all that and then you think of uncommon conditions. Okay.
Okay.
Anything else? Any doubts? Okay, so presentation. If you're not sure, like don't mention about vocal resonance, because just because you wanted to present as a pneumonia, we have some findings which are not very thick. Don't mention those findings, right? If you're not going with your diagnosis, or you must give a diagnosis appropriate for your findings, right? So there should not be a clash in the findings and the diagnosis. That is very, very important.
So omission is better than commission. Either you say that you were not able to make out something, or better than committing something and saying you will not be able to explain the finding means it's difficult. So better to say I was not able to make out how it is. Okay, but you can't say uncooperative child or whatever. You may say that because generally pediatricians don't like the term saying uncooperative child, because we expect the child to be uncooperative, but in spite of it, we should be able to elicit the finding. So we can't expect the child to cooperate with us. So don't use that term. Don't say uncooperative child or hostile child or whatever. So you can say that I am not very clear about it. If you say that vocal resonance or something, you can say I am not very sure about it. So that you can always say rather than committing something. Okay.
Okay.
Tirumurugan sir.
Yes, ma'am.
We are through, sir.
You have completed. Thank you very much, ma'am.
So 1 minute, sir. 1 minute, sir. On
Yeah.
behalf of Keelpark Medical College, I thank Meghale madam for agreeing to chair this session and guide the students, question and guide the students. Thank you very much, ma'am. And I thank IAP.
Because this is my first class for the undergraduates through the Zoom. So thank you for initiating me into this process. And thank you, students. They have done very well. So all the very best for your exams. You should come out in flying colors. Thank you so much.
Thank you.
Thank you very much, ma'am.
And
I think
students,
on behalf of IAPTNSC, I should thank both of you, Dr. Meghale and Dr. Sridevi, for accepting to present the case at a very short notice. I think we had less than 5 days, and I think you did a very fantastic job of guiding through the discussion. It's one of those more let me put it like a very entertaining discussion. I mean, a very knowledgeable discussion which went on today. Thank you very much, Dr. Meghale madam and Dr. Sridevi. It was wonderful having you, and hope to have you more in the future. Thank you very much on behalf of IAP.
I thank IAPTNSC for the opportunity to our college, and I thank all the students who did extremely well. You all did very well, pa. Congratulations.
Today's discussion was really good, madam. I think it was a very good discussion.
And I hope you all do the same in your exams and come out in flying colors. And thank you all students. And thank you, madam. Thank you, Tirumurugan sir, for your,
thank you very much, madam. Thank you very much. Nice meeting you all.
For your consistent efforts in improving the UG as well as PG teaching.
Thank you, madam. Thank you. Nice meeting. Thank you very much. Okay, madam.
Thank you, sir.